Grand Rounds. So today our speaker is Rebecca Fausel. She was born and raised in Portland, Oregon, went to Yale for her undergrad degree, and competed in both varsity swimming and on the cross-country teams. She got her MD at George Washington University and then completed her internal medicine and GI fellowship at the University of Washington. That wasn't enough training, so she did an additional year of a specialty training in inflammatory bowel disease at Mount Sinai in Manhattan, and then she's been back here and joined the Oregon Clinic, and we're happy to hear her talk to us today on promises and limitations of new therapies for inflammatory bowel disease.
All right, thank you. Okay, this sounds like it's working well. Can everybody hear me? No. No? Okay. Anybody? Can everybody hear me now? Yes. Okay. So thank you, everyone. Thank you for the nice introduction, and thank you for inviting me to speak at Providence Portland Grand Rounds. I'm really happy to be here, very excited to be here, and very excited to be back in Portland after many, many years away and trying to get back all that time. So today I want to talk about inflammatory bowel diseases like Crohn's disease and ulcerative colitis, which is my area of specialty within GI, and I want to specifically talk about some of the new therapies for IBD, because we have a fair number of new therapies. There's been sort of an explosion of research over the past 5 to 10 years on new IBD therapies, and we have promises for many more in the years to come, so it's a really exciting area and a really exciting way we can help our patients even further. So this is the first question and answer of the day. So yes, I am related to Dr. Craig Fausel, and he is my dad. And although we've tried to get our other family members to do GI as well, to have a GI, sort of Fausel GI dynasty, that hasn't succeeded yet. But my sister is still in medical school, so we have some hope maybe that will happen. But all joking aside, I do have really fond memories of Providence, Portland. Growing up, I went with my dad to Take Your Daughter to Work Day, and I loved it. It was amazing, and obviously something stuck, and I'm a gastroenterologist now. And I remembered walking in today that I also did summer research at the Earl Childs Research Institute. I had forgotten about that. That was a really great experience, too. So, like I said, I'm really happy to be back in Portland. I thought it might never happen, but you already heard I was all over the country for my training, and I had a really great experience at University of Washington for my residency and fellowship, and also was a hospitalist for a year at our county hospital at Harborview, which was a fun and challenging experience. And then I got this really great opportunity to do an advanced IBD fellowship at Mount Sinai in Manhattan, which is an experience unto itself. This picture is taken by my husband from Central Park, and that is Mount Sinai there. And I thought it looked really very cool, so I took it for my slideshow today. And it was a really amazing year. Mount Sinai is the birthplace of Crohn's disease. And they have a really rich history of IBD research and amazing IBD care. And I got to work with some of the leaders in the IBD field, so that was really an amazing experience. These are just some of the people I got to work with. Dr. Colin Bell actually came over from France, where he did all of his previous work, and now works at Mount Sinai, and he's a character. And he basically has been involved in many of the major clinical trials for inflammatory bowel disease. And then I got to work with all these other really wonderful people, Dr. Dubinsky, Dr. Sands, Dr. Kornbluth, Dr. Mary, and Dr. Ullman. So like I mentioned, Crohn's disease was discovered at Mount Sinai in 1932. I learned a little bit more about this when I was there. It was published in the Journal of the American Medical Association, and there were 3 authors on the article. There was Burl B. Crohn, who obviously the disease was eventually named after him, Leon Ginsberg, a surgeon, and Gordon Oppenheimer, also a surgeon. And the surgeon who actually performed all of the surgeries included in this case series, named Berg, elected not to have his name on the paper for who knows what reason. They elected to list their names alphabetically. So if he had wanted to have his name on the paper, we may call it Berg's disease, but we do not. We call it Crohn's disease. And this is a picture of Dr. Ginsburg and Dr. Crohn. Dr. Crohn is the one who's seated in this picture. Let's see if I have a pointer. Yeah. Oh, yeah, there we go. Dr. Crohn is the one who's seated here. This is Dr. Ginsburg, and this was in 1982. So I think Dr. Crohn was 98 years old at that time. But their original paper, this is just a quotation from their original paper, but they described the pathology and clinical details of a disease of the terminal ileum that affected mainly young adults, that was characterized by subacute or chronic necrotizing and cicatrizing inflammation, which is sort of scarring or stricturing inflammation. And there was ulceration of the mucosa with a connective tissue response, leading to stenosis of the lumen and fistula formation. So there were a few previous descriptions of this in the literature, but nothing that had this many patients, and it was then, after that referred to as Crohn's disease. So today I'd like to talk first about the characteristics of Crohn's disease and ulcerative colitis, about the epidemiology, the etiology of the disease, which we still don't fully understand, obviously, how to diagnose it, what our treatment options have been, and what our more newly available therapies are, some drugs that are in the pipeline that may be coming out pretty soon, and then other pearls about monitoring therapy and monitoring disease. So inflammatory bowel disease is a chronic or relapsing immune activation or inflammation within the GI tract. As we all know, there are two forms. There's Crohn's disease and ulcerative colitis, which I'll talk about both in more detail. But in about 10% of cases, we can't determine whether it's Crohn's disease or ulcerative colitis. So we call it IBD undetermined or indeterminate colitis. And interestingly, reassigning between Crohn's disease and ulcerative colitis is as high as 9% in the 2 years after diagnosis. So they clearly have some overlapping features, and some patients will evolve in one way or the other. And then another form of inflammatory bowel disease is pouchitis that occurs after patients have a colectomy with a J-pouch. And then there's discussion that other microscopic colitis, like lymphocytic colitis, and collagenous colitis may be included in this group, but that's not the focus today. So this is just a table of the characteristics of Crohn's disease and ulcerative colitis and how they are distinguished from each other. So Crohn's disease can be located anywhere from the mouth to the anus. You can get oral ulcers and anal involvement like perianal abscess, perianal fistula, anal fissure, and anal canal ulcer. All of those things can happen from Crohn's disease, although the most common place is in the ileum and proximal colon, the terminal ileum and proximal colon. Whereas with ulcerative colitis, as we know by the name, it only involves the colon. In Crohn's disease, the distribution can be discontinuous. You can have skip lesions, and that's very common, whereas with ulcerative colitis, you expect it to be contiguous from the anal verge proximally. Crohn's disease can involve all the layers of the intestine from the mucosa to the serosa, which is why you can develop strictures, fistulas, perforations, and ulcerative colitis involves only the mucosa. And they're classic presenting symptoms. Not all patients read the book or follow these guidelines, but classic presenting symptoms for Crohn's disease can be abdominal pain, diarrhea, weight loss. And for ulcerative colitis, the classic symptom would be bloody diarrhea. And as we know with Crohn's disease, there are complications of the disease that I'll talk about a little bit more later. So there are strictures or narrowing of the bowel. There are fistulas or abnormal connections between organs. Patients can develop abscesses, microperforations, and even frank perforations from Crohn's disease. In ulcerative colitis, strictures are extremely uncommon, and one of the complications with severe colitis can be toxic megacolon. And on pathology in Crohn's disease, you may see granulomas, but you may not. It's not required for the diagnosis of Crohn's disease. In ulcerative colitis, we don't expect to see granulomas. And this is just a better schematic of a nice diagram of what I just talked about. So this is the Crohn's disease side, and this is the small bowel. And you can see there's transmural inflammation, fissuring here that can lead then to scarring and stricturing. And this is an endoscopic view, and you see these linear ulcers with some relatively normal intervening mucosa here, which is more classic for Crohn's disease. And you can see there are these skip lesions in the bowel, and it can affect any portion of the bowel. And with ulcerative colitis over here, you see this is an inflamed mucosa. It's continuous, as in this picture as well, and you see this just diffuse redness, exudate, erythema, edema, and that's more consistent with ulcerative colitis. So there's a bimodal distribution at time of diagnosis for both ulcerative colitis and Crohn's disease. The most common age is between 18 and 30 years old, so in young adults, but there's a second smaller peak in older patients around age 60. And the incidence for each of these diseases is as high as 20 per 100,000 person years. That's in North America, where it's the highest. And the incidence is rising, and it's thought maybe related to industrialization, maybe related to just improved access to care, or maybe better diagnostics. And then the prevalence is about 200 per 100,000 adults for each of these diseases, and that's also rising. And the highest rates are in North America, in Northern Europe, and in Australia, and there's much lower rates in Asia. And then we have little data from some other countries, as you can see here. This is an article from 2015 about the incidence of inflammatory bowel disease. And you can see that clearly there's a high incidence in North America here, in Northern Europe, Australia, and then we have very little data from Africa, and then we have low incidence in Asia. Interestingly, there seems to be a north-south gradient that I don't think anyone fully understands. It's maybe related to sunlight exposure, maybe related to vitamin D levels, but it appears that diagnosis of ulcerative colitis or Crohn's disease is higher in more northern latitudes. Also, in Crohn's disease, there's a slight increased risk in women compared with men. That's reversed in children. And then in ulcerative colitis, a slight increased risk in men compared with women. And then, of course, tobacco use is a really important factor. We all know that's very important as it relates to inflammatory bowel disease. In Crohn's disease, tobacco use increases the risk of developing the disease with a hazard ratio of 1.4 to 1.9. And in ulcerative colitis, there's an increased risk of developing ulcerative colitis if the patient is a former smoker, but not if they've never smoked or if they currently smoke. So, maybe they shouldn't stop smoking. No. But yes, so that's an interesting thought. And actually, though, they've tried treating patients with ulcerative colitis with nicotine patches, and that was not effective. So it's interesting. This is just a figure to show the north-south variation, how the incidence of Crohn's disease and ulcerative colitis is higher in the northern latitudes compared to the more southern latitudes here. As we know, there are higher rates of inflammatory bowel disease in patients with Jewish ethnicity and higher rates in whites, although it can have, IBD can be present in any ethnicity. And in patients who have inflammatory bowel disease, 10 to 25% have a first-degree relative with IBD. And so that portends about a 3 to 20 time greater risk than the general population. Usually, if they have a family member with inflammatory bowel disease, it's the same type of disease, like Crohn's or ulcerative colitis. Usually, it's generally in the same location and the same severity, but that's not always the case. And there's a 50% concordance rate in monozygotic twins for Crohn's disease and only a 19% rate for ulcerative colitis. Now on to the etiology of inflammatory bowel disease, and this we're still really trying to decipher. There's thought to be four main factors at play. There's certainly genetic factors that we're still unraveling. There are environmental factors, which I will mention as well, but we still really don't have a great sense of all of the environmental factors involved. And then absolutely there's an altered immune response, a dysregulated immune response to intestinal flora in the gut. And perhaps it's related to certain intestinal flora. We're still also trying to decipher that. So for genetics, there are 242 distinct susceptibility loci for IBD. So just a few, and that's been growing. Lots of new genetic studies. But most of those susceptibility loci involve one of these pathways. So one is the intracellular innate immune pathway that recognizes microbial pathogens. One of the mutations in that pathway is called NOD2, which is involved in ileal Crohn's disease. And that's just a problem with sensing the microbial pathogens and reacting appropriately and activating the innate immune system appropriately. And so that when that is mutated, then there's increased permeability of the intestine, and then you end up with chronic inflammation. In addition, some of the genetic loci look at autophagy, have code for autophagy, which is when segments of the cytoplasm are isolated within a membrane and delivered to lysosomes for degrading. And that's the process through which old or misfolded proteins are cleared, and the process through which apoptotic bodies are cleared. And it's also involved in directly killing pathogens and activating toll-like receptors, as well as activating antigen-presenting cells. It's a really important part of our immune response to pathogens, and that's perhaps involved in the pathogenesis of Crohn's disease, and then, or of inflammatory bowel disease, I should say. And then additionally, there are other genetic mutations, genetic factors associated with the adaptive immunity, epithelial function, and the major histocompatibility complex. And this is just a slide with many of the genes we've discovered to be susceptibility loci for inflammatory bowel disease. You can see that a lot of them overlap between inflammatory bowel disease and ulcerative colitis. Between Crohn's disease and ulcerative colitis. But many of them do not. And then it's also been found that many of them are shared among other autoimmune diseases like type 1 diabetes. So the next step in the etiology is that the dysregulated immune response to the microbiota. So probably related to these genetic susceptibility loci, patients with inflammatory bowel disease have a dysregulated immune response to the sort of normal microbiota that resides within the intestinal lumen. So either their response is too strong or it's inadequate sometimes. They can have alterations in the intestinal mucosal epithelial barrier. They can have increase in intestinal permeability. And then other things we target with our medications are excessive immune cell recruitment and activation, and homing of leukocytes to the diseased mucosa, which leads to more inflammation, as well as increase in these immunoregulatory and inflammatory cytokines. And this is just a little diagram of what I just talked about. So you can see that, so first you can see there's an impaired barrier function. These microbial organisms are able to enter the intestinal cells, and then that leads to immune cell activation. There's a failure of regulatory mechanisms of these regulatory T cells. There we go. And a production of pro-inflammatory mediators as well. And this leads to chronic inflammation and then other complications of disease. We also know that, like everything else now, probably the human GI microbiome plays a role in the development of inflammatory bowel disease. We don't fully understand this. There's a lot of research ongoing. We know that the human GI microbiome contains between 15,000 and 36,000 species of bacteria, and the distal ileum and colon contain high concentrations of microbes. And we also know that genetically susceptible mice who are put in germ-free environments don't develop colitis until the normal germs are until they're put back in the normal germ environment. So what we do know so far about the microbiota in IBD is that there's a decrease in diversity of the microbiota in IBD, and there's a reduction in certain types of bacterial species, like the firmicutes and the Bacteroidetes. And these bacteria normally produce short-chain fatty acids that nourish colonocytes, so perhaps this plays a role. And there are other types of bacteria that are depleted in the ileocolonic mucosa. But we still don't really know how this will affect treatment. But it's an area of intensive ongoing research, and a lot of patients are interested in the idea of fecal transplant, which I'll talk about a little bit later. So there are also environmental factors that we don't fully understand. We know that breastfeeding is protective against the development of IBD. We know that patients with higher socioeconomic class have a higher rate of developing IBD. There's possibly an association with oral contraceptive use. And then there's also this possible association with higher intake of refined sugars, lower intake of fresh fruits and vegetables, Although an article I read suggested maybe that was because they had some early inflammation and then fruits and vegetables made them feel worse. So who knows? Also possibly in association with NSAIDs. And then we also do know there is an association, an increased risk of developing IBD in patients who get antibiotics in childhood. So here are the symptoms to think about IBD and referral over to us. So of course, if patients are seeing blood in their stool, that's a good reason to refer. Weight loss can be a sign of malabsorption and inflammatory bowel disease. If they're having diarrhea, particularly with nocturnal bowel movements, of course, thinking about if they have a family history of inflammatory bowel disease. And also, particularly if they have anemia, elevated inflammatory markers, those are concerning for inflammatory bowel disease. Sometimes Crohn's patients won't present with diarrhea. They'll present with some obstructive symptoms like colicky abdominal pain, maybe associated with nausea and vomiting. And then obviously if patients have perianal abscess or fistula, particularly if it's recurrent, that would be a good time to think about Crohn's disease. And also if they have recurrent or refractory anal fissures. With Crohn's disease, they tend to be sort of eccentric, a little different location, and can be harder to treat. And sometimes with Crohn's disease, the symptoms can be very subtle. It can take a longer time to diagnose it, and 25% of patients aren't diagnosed till over 2 years after their initial presentation because it can be so subtle. So symptoms like anorexia or weight loss, and in children can just be growth retardation sometimes. So good to keep that in mind. So in terms of diagnosis, obviously colonoscopy is always the best way to go, but we don't really have a gold standard criteria for diagnosis. We look at lab work, we look at stool tests. Obviously colonoscopy and pathology results are really important. And then of course we want to rule out other possibilities like infection, we want to rule out ischemia, drug-induced injury, other disorders like Behçet's disease, etc. Right, so these are some of the biomarkers we can look at when we're looking at inflammatory bowel disease or looking to diagnose inflammatory bowel disease. We certainly do not use the majority of these, but you can look at the C-reactive protein. That's a good one to measure that will help assess if there is inflammation, although a percentage of patients never mount an elevated CRP even when they have severe inflammation, so doesn't officially rule out the possibility of inflammatory bowel disease. Sometimes we can look at the sedimentation rate as well. And then ferritin can be helpful to look for slow blood loss. Albumin is very helpful because it can be low in patients with severe colitis and can also be low, of course, if there's malabsorption due to Crohn's disease. And it can affect sometimes the therapy and the efficacy of therapy. And then, of course, the platelet count can be high because of inflammation or because of iron deficiency. And the white blood cell count can also be high in setting of severe inflammation. And then this other one, calprotectin, is a relatively newer test that we are looking at that is also it is helpful in assessing for inflammation. And we don't do any of these other ones here. So the fecal calprotectin is obviously a stool test. It is a protein that's derived, calprotectin is a protein that's derived from neutrophils and monocytes, and it's a marker of neutrophil activity. So we know that the levels are increased in intestinal inflammation, and we know that it can be useful for distinguishing inflammatory diarrhea from non-inflammatory chronic diarrhea. It has about a 93% sensitivity, so it's not perfect, and we could miss inflammatory bowel disease, but it has a pretty good specificity at 96%. And there was a relatively recent study that looked at the combination of CRP and calprotectin, and if they're both low, CRP less than 0.5 and calprotectin less than 40, there's a less than 1% probability of IBD, so very unlikely, still possible, but very unlikely. We use that usually as an adjunct test. Sometimes or often we frequently still require endoscopy, and of course if it's elevated we would do a colonoscopy to further assess. We also use fecal calprotectin to monitor our inflammatory bowel disease patients, to monitor their response to treatment and to try to avoid colonoscopies sometimes. So this is just pictures of ulcerative colitis to show the usual features that we see on endoscopy. So you can see up here, this is a mild form of disease. You see just mild erythema and edema, maybe loss of the normal vascular pattern. And then as we go down here, you can see it gets more severe and more severe. You're seeing ulcers, you're seeing severe friability, erosions, and just spontaneous bleeding in the last picture, and that's very severe. And we know that there is continuous involvement from the anal verge proximally. And you can see pseudopolyps. You can see that in Crohn's as well. So the disease distribution in ulcerative colitis, so it can be proctitis, it can be left-sided colitis up to the splenic flexure, or it can be pancolitis. And usually you can see the percentages here. 30% have disease limited to the rectum, 40% have left-sided disease, and another 30% have disease that involves their entire colon. So here are some pictures of Crohn's disease, endoscopic pictures of Crohn's disease. So you can see there, some of these pictures show cobblestoning, which is ulceration separated by relatively normal appearing mucosa. You can see this picture here shows an aphthous ulcer, which is one of the earlier signs of Crohn's disease, and it's surrounded by normal appearing mucosa. You can see this is severe ulceration, serpiginous ulceration here. And then this looks like a narrowing, a stricture, what it looks like on endoscopy. And as we mentioned earlier, you can see segmental involvement, healthy mucosa intercalated with diseased mucosa, and you can see rectal sparing as well, which would all be features of Crohn's disease on colonoscopy. It's really hard to see fistulas sometimes on colonoscopy. So here's the usual Crohn's disease distribution. So the majority of patients have ileocolonic disease, up to 50%. Then there's about 20% who have only involvement of their colon, and about a third of patients have only involvement of their small bowel. As we know, it can be anywhere in the GI tract, but those are the most common. And then they can also have jejunal involvement, although it's very rare to have jejunal involvement alone without involvement of other areas. And it's also very rare to have gastroduodenal involvement without involvement of other areas as well. And esophageal involvement is also very rare at 2%. Here are some clinical features of Crohn's disease, like we mentioned. Crohn's disease is classified into B1, B2, and B3 disease. B1 disease is when it's mostly inflammation that's driving the symptoms, and you can see that this is an inflamed segment of bowel here, and you can see the symptoms with that would be diarrhea, abdominal pain, maybe a fever, weight loss, and fatigue and malnutrition. On this picture, you can see this has progressed, and it has become more of a strictured area, a narrowed area, and so that's called B2 disease, and patients present with obstructive symptoms like nausea and vomiting, bloating, postprandial abdominal pain. And then over here, B3, that's when patients develop fistulas. So they can develop fistulas to any organ, but fistulas can happen within parts of the bowel, they can happen to the bladder, to the vagina. It can occur to the abdominal wall as well. And so, of course, the symptoms for that depend on where the fistula is located. This is just a diagram of the natural history of Crohn's disease. So we know that in the beginning, Crohn's disease is predominantly inflammatory. And as time goes on and inflammation continues, that's when patients develop strictures, fistulas, require surgery. And this would be what would happen without appropriate medical therapy to try to control the inflammation. And of course, there are also extraintestinal manifestations of inflammatory bowel disease that I won't talk about in detail, but are good to know about. So in the eyes, there's episcleritis and uveitis that can occur. In the mouth, of course, we talked about aphthous ulcers. Stomatitis can happen. In the liver, of course, we have to think about primary sclerosing cholangitis whenever we see abnormal liver tests in our patients. In the kidneys, these patients are at increased risk for kidney stones. And of course, there's always a risk for fistula to those organs. And then dermatologically, there's pyoderma gangrenosum, which is this picture here, which can be quite severe. As well as erythema nodosum is another dermatologic manifestation of inflammatory bowel disease. And they also get joint manifestations as well with arthritis. Okay. So our goal with therapy is to induce remission of their disease, and then to maintain remission without steroids, to prevent complications, to prevent the need for hospitalizations, and to prevent the need for surgery if possible, to, of course, improve their nutritional status, to achieve and maintain mucosal healing, which is a relatively newer objective, but now we know that mucosal healing is associated with better outcomes, less risk of complications and hospitalizations. Of course, our goal is to improve their quality of life, and of course, prevent disease-related morbidity and mortality. So this is just a little timeline of what has been used for inflammatory bowel disease over the years. So back in the 1970s, we didn't have many options. There was sulfasalazine and corticosteroids, basically. And then over the years, in the 1980s, we had a study on 6-mercaptopurine that showed its efficacy, same class as azathioprine, showed its efficacy in Crohn's disease, in inflammatory bowel disease. And so that was, people started using that in the 1980s. In the 1990s, we got the 5-aminosalicylates like Lialda, Acecol. We then got budesonide, methotrexate. And then finally, in 1998, we had the first approval for a biologic for inflammatory bowel disease, which was infliximab for Crohn's disease. And then it took 7 more years, and we got infliximab approved for ulcerative colitis. So it's only been 12 years since it was approved for ulcerative colitis. And then adalimumab came after that, then certolizumab and natalizumab all in succession. And then eventually we more recently had golimumab for ulcerative colitis, which is also an anti-TNF agent, vedolizumab, which is a newer anti-integrin agent, which I'll talk about, in 2014. And then most recently, we had approval for ustekinumab for Crohn's disease, which was just about less than a year ago that it was approved for Crohn's disease. And it was previously approved for psoriasis, but now we have it for Crohn's disease. So I'll just briefly go through our therapies now. So 5-aminosalicylates, I should mention, I'm not going to go through every single one of them. I'll go through most of them. So 5-aminosalicylates are what we often use for mild to moderate ulcerative colitis. So we don't really understand its exact mechanism of action. It's thought to act topically, maybe inhibit cytokines, has free radical scavenging, and inhibits white blood cell adhesion, but still really, we don't really know exactly how it works. And there's been a question of whether it has a possible chemoprotective effect against developing colon cancer, but that's unclear. So like I mentioned, we use it for induction and maintenance of mild to moderate ulcerative colitis. So sulfasalazine induces remission in somewhere around 50% of patients, and 5-ASA therapies have similar efficacy. We do know that all of the formulations of 5-ASA, the Lialda, Acecol, balsalazide, Pentasa, etc., they all seem to have pretty similar efficacy, so you don't have to choose one over the other. Usually insurance dictates that, but we do know that higher doses of 5-aminosalicylates are more effective for the moderately active disease, and then you generally continue whatever you started once they're in remission. And we also know that topical therapies like enemas and suppositories can be used for patients who have proctitis or just left-sided disease, and that the combination of both oral and rectal 5-aminosalicylate is more effective than either therapy alone. And then very important is that we now know that these therapies, 5-ASA therapies, 5-aminosalicylate therapies, are not effective for small bowel Crohn's disease, so they have no role there. But they do seem to have a role for mild Crohn's colitis, and they seem to be effective there. So usually these medications are extremely safe. There's a very slight risk of a reversible acute kidney injury, so we monitor their creatinine yearly. And there's a rare chance they can actually get worse, have worsening of their colitis from these medications, which is unusual, but it can happen. And then rare chances of pancreatitis or pneumonitis. So we all know about corticosteroids. We still use them. Sometimes we need them. They are highly effective. Their response is rapid, and they're inexpensive. And they work well for inducing remission in moderate to severe ulcerative colitis and Crohn's disease. They have many disadvantages, though, that we all know about. So weight gain, there's a risk of infection. They cause hyperglycemia and hypertension, osteoporosis, avascular necrosis, and mood and psychiatric side effects, among many other things that I didn't list. So we usually start at about 40 milligrams a day, and we usually taper over about 8 weeks if we're using them. Of course, we try to only use them when we have to. And there's no role in maintaining remission with steroids. And we do know, very importantly, that steroid use is associated with increased mortality in Crohn's disease, so an odds ratio of 2.1. So that's important information. So for that reason, we do try to avoid them whenever they're not necessary. There's another topical version of steroid that we do use. Budesonide has a controlled ileal release formulation, and it is effective for inducing remission in ileal or ileocecal Crohn's disease, about 47% versus 22%. Usually we use it for patients with pretty mild, maybe mild to moderate, mostly mild disease. It's less effective than other glucocorticoids like prednisone. Really doesn't have much data for maintenance of remission. But the benefit is that there's a 90% first pass metabolism in the liver, and so we get much less systemic corticosteroid exposure and much less suppression of the HPA axis. And so there is possibly a slight reduction in bone density over long-term use. So that's something we should think about monitoring, but otherwise it seems pretty safe. There's a newer version of budesonide called budesonide MMX that is a colonic release formulation. It is more effective than placebo for inducing clinical and colonoscopic remission in ulcerative colitis. And usually its use is if patients aren't responding to 5-aminosalicylate therapies. It can be sort of a temporizing measure for mild to moderate ulcerative colitis. But it also is not effective for maintaining remission. It's for induction only. And it has very minimal absorption and no association at all with any change in bone density at all. So sometimes we use antibiotics, not that often, but certainly we use them. So we use Cipro and Flagyl. We use that for pouchitis. We use it for perianal fistulizing Crohn's disease. But we always use that in conjunction with another therapy for perianal fistulizing Crohn's disease. And the benefit of use of antibiotics, it goes away as soon as you stop them. So it's really used for patients who have abscesses or some active infection usually. There is a role for Flagyl as postoperative prophylaxis in Crohn's disease after an ileocolic resection, although a lot of patients can't tolerate it because of side effects, peripheral neuropathy and other side effects. And then rifaximin is used for mild Crohn's disease in some cases. Hard to get approved, perhaps. And then there's no role for antibiotics in ulcerative colitis. We do still use thiopurines like azathioprine and 6-MP that was first suggested for its use in 1980, and it's still effective today. So thiopurines, they're 6-TG nucleotides, and they inhibit purine synthesis. They inhibit proliferation of B and T lymphocytes and lead to apoptosis of B cells. We use weight-based dosing for these therapies. We check an enzyme called thiopurine methyltransferase before we initiate therapy. That's very important, so we know if the patient has none of that enzyme that they will not tolerate this medication. We know that this is a slow-acting medication. It takes 3 to 6 months to see full effect, so it's not used alone for induction of remission. It's not sufficient for that. It does have some steroid-sparing effect, and we use it for both Crohn's disease and ulcerative colitis, but it seems to have lower efficacy than our biologic therapies, and we now use it more as a combination therapy with other biologics. And this is one of the main reasons. So there are a variety of side effects of thiopurines, and typically this leads to drug withdrawal in about 10% of patients. They can develop myelosuppression. We have to check their CBC frequently in the beginning and then every 3 months with chronic therapy. They can develop hepatitis, so we have to closely monitor their LFTs. 3 to 4% of patients get pancreatitis, which is usually mild and resolves with cessation of the medication. Of course, they're at increased risk for infection. They can get a flu-like illness with fever, rash, arthralgias. They are at increased risk for non-melanoma skin cancer, so we do recommend a dermatology exam every year for our patients on these therapies. And then the really scary one that everyone hears about or talks about is this risk of lymphoma with thiopurines, which is a risk. The risk is very small. It increases from about 2 in 10,000 to about 4 to 9 in 10,000, but it's still a significant risk. And usually that starts to occur after 1 to 2 years of therapy with thiopurines. So we often use them in combination with our other medications for 1 to 2 years and then try to stop them. So thiopurines are also associated with nodular regenerative hyperplasia of the liver, which is non-cirrhotic portal hypertension. And then additionally, there's this risk of an extremely rare but fatal hepatosplenic T-cell lymphoma, which also is something that can occur after 1 to 2 years of therapy at the minimum, and more common in patients on combination therapy and more common in young men. So we're pretty careful about starting thiopurines in young men. When we do it, we just try to keep them on it for less than 1 to 2 years. So now, this is what we use most often now, are the anti-TNF agents. We have 3 for ulcerative colitis and 3 for Crohn's disease. We have infliximab for both, adalimumab for both, and then we have certolizumab for Crohn's disease and golimumab for ulcerative colitis. And basically, these anti-TNF agents block TNF, and they prevent the pro-inflammatory cytokines. They prevent activation of pro-inflammatory cells, and they actually can also induce apoptosis of inflammatory cells as well. So it's approved for use for moderate to severe ulcerative colitis and moderate to severe Crohn's disease. The initial responses are pretty good, about 60%, but there is a significant percentage of patients that lose response over time, and this is an important problem for us. And oftentimes that can be due to developing antibodies to the medications. So we know that it works, these medications work most effectively when they're given in combination with an immunomodulator. And this study here is called the SONIC trial, and it looked at using infliximab alone or azathioprine alone or infliximab and azathioprine together, and found that patients did significantly better with corticosteroid-free clinical remission if they got both infliximab and azathioprine. They also had higher levels of infliximab, lower levels of antibodies to infliximab. So there's actually a 57% corticosteroid-free clinical remission, which is quite good at week 26. So we often give those together. We give a thiopurine and an anti-TNF agent together unless there are reasons not to. And in patients over 65, that's sometimes a reason not to give both together because there's an increased risk of infection. And then in young men sometimes, or if there are other reasons to do this, or if patients cannot tolerate thiopurines, we sometimes use methotrexate instead of thiopurines. So safety is really quite good with anti-TNF agents, but there are some important things to know about. So we always check for tuberculosis and hepatitis B before we start therapy. We know there's a small increased risk of severe infection, of serious infection, and that's a hazard ratio of 1.4. And we know the highest risk is with combination therapy, and the highest risk is also with steroids. And there's also an increased risk of mortality in patients receiving narcotic medications with IBD, so we also try to avoid those as well. So anti-TNFs had no effect on mortality. This is from a large registry of all the patients who had received Remicade. It's called the TREAT registry. And there is no significant association between infliximab and malignancy risk, which is good to know. And research on that is still ongoing, but the most recent data suggests that there is not an increased risk of developing recurrent cancer with infliximab, although everyone, of course, is concerned about that. Other risks of anti-TNF use include patients can have an infusion reaction, which can sometimes be severe with Remicade, or they can have an injection site reaction from the injectable medications. They can have a delayed hypersensitivity reaction, which can happen 10 days or so after the infusion. They can develop drug-induced lupus, which is really quite rare, but it can happen. There is the induction of autoimmunity with these agents sometimes. They can develop what looks like a psoriasis-type rash, and that usually goes away when you stop the medication, and it recurs about 50% of the time if you start a different anti-TNF agent. They can get liver injury, they can get neutropenia. These are rare things. There's this question of whether lymphoma is associated, and we're still unclear on whether there's a small increased risk of lymphoma with anti-TNF agents alone. probably not, but that there is potentially a small increased risk of lymphoma, and there's a risk of demyelinating disease and congestive heart failure, which are extremely rare. So next are anti-integrin therapies. These are almost the most recent kids on the block. So we now have vedolizumab, which you can see is mentioned here. And anti-integrin therapies block migration of inflammatory cells out of the bloodstream and into the gut mucosa. So we used to have natalizumab, which is an alpha-4 integrin inhibitor that, as I mentioned, prevents leukocyte adhesion and migration into inflamed tissue. But there are also receptors for alpha-4 in the brain and CNS, and it's used also for multiple sclerosis. But because of this, there's an associated risk of progressive multifocal leukoencephalopathy in patients who have JC virus positivity. And so we almost never use it anymore because of that risk, and we have an alternative option in the same class. So the new one is vedolizumab. It was approved in 2014. It's an alpha-4 beta-7 integrin inhibitor. And there are no receptors for this in the CNS, and so there's no cases of PML reported after many thousands of patients have received it. There does appear to be a higher rate of response and remission in ulcerative colitis compared with Crohn's disease, and there are some questions about its efficacy in small bowel Crohn's disease as well. It seems to be perhaps better for colonic disease. It has a great response rate in ulcerative colitis, 65%, but it sometimes can take months to see the full effect, particularly in Crohn's disease, and particularly in patients who have previously failed anti-TNF therapy. And so that can be a drawback to the medication. But the really huge advantage is that it is gut selective. It has a really excellent safety profile. Basically, the only risks that we know of are infusion reaction and increased risk of nasopharyngitis. And we don't know of any increased risk of serious infection, malignancy, nothing like that. So it's a really safe medication as far as we know. This is the newest one. This is ustekinumab, or Stelara, and it's an antibody to IL-23 and IL-12, the P40 subunit of IL-23 and IL-12, so it prevents binding to its receptors and then intracellular signaling of pro-inflammatory cytokines. So we just had it approved. As I mentioned, it blocks the biologic activity of IL-12 and IL-23. There's about up to a 50% response rate during induction and a 50% remission rate at week 44. We give an infusion for the first dose, and then it's given subcutaneously after that. And in terms of safety, it seems to be very safe. There's still some immune suppression involved, but has a very low rate of serious infection. So there's many more therapies that are in the pipeline. There's other anti-cytokine antibodies. There's Janus kinase inhibitors like tofacitinib, which is already approved, or Xeljanz, which is already approved for rheumatoid arthritis and soon hopefully to be approved for ulcerative colitis. We have a variety of other small molecules like anti-SMAD7, which is also called mongersen, more of these anti-leukocyte trafficking agents like vedolizumab, and then another class of agents called sphingosine 1-phosphate receptor modulators, which basically keep lymphocytes from leaving the lymph nodes. And this is just to show that this is just the small molecule drugs that are in the pipeline. And there are many of them, as you can see, and there are many other types of drugs still being developed. So I looked into probiotics because patients always ask us about probiotics, and I wasn't aware of any benefit to probiotics, but I did find a recent meta-analysis that showed that basically there's no benefit for probiotics to induce remission, no benefit in Crohn's disease, but they do appear equivalent to 5-ASA agents in preventing ulcerative colitis relapse, which surprised me. So this is the forest plot for that. But you can see they were equivalent, so that's interesting. This is the probiotics versus 5-ASA for preventing relapse. And then all of our patients also want to know about fecal microbiota transplant. And we obviously do this for C. diff sometimes. And it's just a very popular idea. I've had patients go to England to get it done and just do it themselves as well. But there is a recent systematic review that showed only 36% efficacy, but of course these are small sample sizes. These are really, it's not a not robust data at this point. It looks like certain donors are more effective. So maybe if you have the super donor, that's what you need. And then of course, maybe the success depends on the route you administer it, perhaps. But it's really not ready for prime time. We're not ready for fecal transplant for IBD yet, but we're really working on more trials. And of course, there's concern about transmission of diseases, infectious diseases, and also other diseases that are associated with microbiome, like obesity and other autoimmune diseases. So I'm almost done here. So in the other important little tidbits in inflammatory bowel disease I wanted to bring to everyone's attention and include in my talk. So in IBD, we frequently see C. diff infection accounts for 5 to 10% of symptomatic relapses. The rates of C. diff are increasing, and patients who develop C. diff require colectomy more frequently, up to 20% of the time. So we should always send C. diff when we see a patient with a flare. And typically we treat with PO vancomycin for our IBD patients. Sometimes that's not feasible, but that's generally recommended by expert consensus. And then the other really important thing is to make sure we're putting all of our IBD patients on DVT prophylaxis in the hospital. That can be a difficult thing because they're having rectal bleeding a lot of the time. But they do have a very high or a significantly increased risk of DVT and PE, which can lead to significant morbidity and mortality. So we should always put them on pharmacologic DVT prophylaxis unless there's a really good reason not to. And then healthcare maintenance, this is just minor things to think about. Of course, immunizations. We should avoid live virus vaccines for patients who are on biologic therapy or give it prior to biologic therapy. We should, of course, counsel them to stop smoking if they're smoking. We may need a DEXA scan in patients who have been on chronic steroids. Of course, we need to think about dysplasia surveillance for our IBD patients who have had colitis for 8 years or more, and that's really important. And then I thought it was interesting, vitamin D is something we should probably be monitoring. We know that low levels are associated with an increased risk of disease relapse and increased surgical risk as well. And when the levels were repleted, that surgical risk improved and also associated with disease activity and severity. And then lastly, of course, we need to think about our patients' colorectal cancer risk. We know that these patients are at increased risk. Patients with colitis are at increased risk for colorectal cancer, particularly if they have longer duration of disease. If they have PSC, they need a colonoscopy yearly from the time of diagnosis. Of course, if they have pancolitis, that's a higher risk. And if they have this post-inflammatory polyposis like pseudopolyps, as well as ongoing endoscopic and histologic activity. So those are important things to think about. And after 8 years of disease, we want to do surveillance colonoscopies for our patients with colitis. All right, summary is, so there are important distinguishing characteristics between ulcerative colitis and Crohn's disease, but sometimes we can't distinguish them or the diagnosis may change over time. We know that the pathogenesis of IBD involves many factors, including genetics, environment. We know it involves a dysregulated immune system, and also it involves the intestinal flora, and we're still trying to figure out how that works. In Crohn's disease, it's important to remember that symptoms can be very subtle, and we should keep that in mind. Fecal calprotectin can be helpful to rule out IBD, but often endoscopic evaluation is necessary. And then we know that complications of Crohn's disease can include strictures and fistulas, particularly if we don't control the inflammation well. And we have many effective treatments for IBD, but there are still a lot of patients who don't respond to our therapies, and so we need more options for these patients, and they are coming in the pipeline soon. And it's important for us to remember to check C. diff for IBD flares and give heparin for DVT prophylaxis, and then we should start our patients with dysplasia surveillance colonoscopies 8 years after disease diagnosis. There we go. Any questions? Yes.
The newer therapies greatly decrease the need for surgery, especially in UC, or are they just delaying the need for surgery?
Yeah, it's a good question. I think we still need more data on that. I think there's been some evidence that the rate is decreasing, but I think we still need more studies on that. It's a good question.
Comment on the cost of the various therapies?
That's a great question. The 5-aminosalicylate therapies can be expensive if insurance doesn't cover them, so they can be fairly expensive for the patients. The thiopurines are very inexpensive, 6-MP and azathioprine. Remicade, Humira, Cimzia, Golimumab, they are all very expensive. I don't remember the exact number per year, but certainly around, I believe, 30,000 or so. And ustekinumab is even more expensive than that, is my understanding. Yes?
With some of the other inflammatory arthritis, there's a lot of cardiovascular disease risk. Has that been worked out with inflammatory bowel disease?
I don't believe so. I haven't heard that. Yeah, that's a really good question. I haven't heard about it in association. Yes.
Are there any particular diets that you recommend for these folks?
I thought about putting that in too. That's a great question. There's a lot of research ongoing into that. There's some data for a specific carbohydrate diet in children and pediatrics. There's not much good data on diet in adults. And so we typically recommend, we don't think it necessarily affects inflammation. We just recommend that they sort of eat a well-rounded diet and what they can tolerate, what affects their symptoms. And of course, if they have strictures, we tell them a low residue diet. But there's a lot of research ongoing for that. And there is some data on using tube feeds, exclusive enteral nutrition that can actually induce remission in Crohn's disease as well. But it's hard to do.
I was just wondering, Northern European, higher rate Northern America, red meat comes to mind compared to Asia, for example.
Sure.
Any work on?
I don't think that's been studied, but that's a really good thought. I do think people might think it's westernized diets, sort of industrialization, but not specifically red meat. I don't believe that's been looked at.
Any improvement on people that are given parenteral nutrition?
No, not that I'm aware of in terms of healing the intestine, although bowel rest can be helpful for the short term, absolutely. For some of these patients, I have seen it done, but I don't think there's any data for long-term management with TPN.
This appears to be a really complicated field. Even just to pronounce the names of these drugs takes special training. And I'm wondering, is there going to be a trend among gastroenterologists only a few people should treat inflammatory bowel disease? Out in the community, Eastern Oregon.
I think there is a trend, at least for more complex cases, to have IBD specialists. But I think, for average cases, I think all gastroenterologists are very well equipped to handle it. But I think it's great to have IBD specialists for the more complex ones, which are becoming more frequent too.
Calprotectin positive in other inflammatory colitis as well?
That's a great question. I do believe it would be. It would make total sense. So I don't think it's a very good test if it's an acute diarrhea, because then it could be infectious. I mean, I would think it would also be, since it measures neutrophil activity, I would think it would also be high with any type of colitis. For intestinal inflammation. Yeah, for determining non-inflammatory versus inflammatory. Yeah.